Welcome back. Now that you have completed Part 1 on interpretation of ABG results, we'll move on to Part 2 and focus on the arterial puncture procedure. In this part of the tutorial, I'll focus on teaching you how to perform an arterial puncture, giving you some tips on techniques along with an organized approach to the procedure. We'll also take some time to review the important aspects of the Cedars-Sinai policy that govern arterial puncture. Let's begin with the indications for an ABG. Sounds pretty basic, but I think it is important to review. We work in a teaching environment, and it's not uncommon that the less experienced providers look for additional data to support and guide their clinical decisions. However, repeated arterial punctures increases your patient's risk for complications and should be done only when necessary. We'll discuss the associated complications in a bit. For now, let's review the indications for an arterial blood gas. First, to determine a patient's acid-base balance and gas exchange to guide treatment and optimize patient care outcomes. The second part of the statement is the one I think we sometimes fail to remember. And the question you should ask yourself is, do I need an ABG? Will it tell me something more than my bedside assessment to guide a clinical intervention, to make a difference for my patient? If the answer is no, probably not, or I'm not sure, consider talking with your physician colleagues and reconsider the need for the test. With any and all clinical procedures, it's important to follow a consistent process and proper procedure to ensure quality and safety. First off, be certain to have a physician's order. And with every clinical procedure here at Cedars, be certain the person performing the procedure is qualified. Qualification here includes any licensed MD, RN, or respiratory care provider that has successfully completed the didactic and clinical training covered in this course. As part of their clinical training, they'll need to perform 3 separate successful supervised arterial punctures. You'll receive a sign-off sheet for this activity at the end of class today. Any certified personnel can observe and sign you off. When this is complete, be certain to get this documentation placed in your employee file to finalize your certification. Everyone must observe strict safety and infection control standards, and we'll get into these specifics shortly. And finally, everyone performing ABGs is responsible for following Cedars policy governing this procedure. A copy of the policy is part of your course handouts today. Before performing an ABG, let's go through a list of considerations that emphasize safety and infection control to support your patient around this procedure. Verify the correct patient using 2 identifiers. Always use your lab label in this process. No shortcuts here, folks. I can tell you from my own experience that this is particularly helpful in reducing errors when you're doing lab draws for other providers. Be certain that you perform a modified Allen's test before doing any ABGs. We'll talk in more detail about what this test is and why it's essential, as well as how to perform it in just a few minutes. Also be prepared to document your results of this test on your ABG lab requisition slip. Select the radial artery on the non-dominant hand as a first choice. A complication on the non-dominant hand has fewer consequences for the patient. And also, I want you to be aware that this certification class does not cover brachial or femoral arterial puncture certification. Be sure to maintain an aseptic technique. And also consider the use of lidocaine to mitigate the pain associated with arterial punctures. I want to take a few seconds to encourage you to really evaluate whether your patient could benefit from the use of lidocaine. More often than not, I find that we don't offer it to our patients. But you can easily incorporate this assessment into your patient teaching. It only takes a few minutes to prepare the injection as well. I've found that some of our younger, more alert or anxious patients seem to benefit the most from this preparation. You'll want to start this procedure by positioning your patient to optimize their comfort and your success. So what I suggest that you do is have your patient in a supine position and get the level of the bed comfortable for yourself. Place a towel roll or a couple of face cloths rolled up behind the patient's wrist to support hyperextension. This will bring the artery closer to the skin surface and make it a little bit easier to palpate. You'll want to select the standard 23 gauge 1-inch needle found in your ABG kit to perform your radial ABG. It's unlikely that you'll need the 22 gauge 1.5-inch needle for the arterial stick. Those are generally reserved for the brachial or the femoral punctures. Use a 30 to 60 degree angle. This is acceptable for the procedure. In previous classes, I have been asked if a 90-degree angle or a straight up and down positioning is acceptable. It's not. If you've observed this with other clinicians, it's not an acceptable technique, as it's unlikely that you're going to be able to get the entire bevel of the needle in the artery, allowing for adequate blood return and successful puncture. But rather, you're more likely to, hit the posterior aspect of the vessel and actually go right through the vessel, getting a flash of blood and an inadequate blood return. And you're just placing your patient at risk for vessel injury and excessive bleeding. So, if a 90-degree angle is acceptable for the femoral artery punctures, but not for a radial artery puncture. You'll also want to be cognizant of post-puncture care needs and plan accordingly. The primary concern here is to build in enough time to support your patient and maintain post-puncture pressure for a minimum of 5 minutes. Cover it with a Band-Aid and reassess the site a few minutes thereafter. So if you're urgently drawing an ABG and your patient is anticoagulated, you might want to tell a buddy so they can swing by and pick up your specimen while you maintain an adequate amount of pressure. Be aware that if your patient is anticoagulated or has any underlying blood dyscrasias, that this will increase their risk of bleeding and its associated complications. In these cases, you'll just want to take the time to explain this to your patient and maintain pressure longer to reduce their risks. Okay, now on the other side of the coin, let's go through a list of considerations that emphasize safety and infection control around this procedure in terms of your preparation. First and foremost, hand washing. This is a basic standard of care that should never be overlooked. Consider a gown as an extra precaution for patients who are agitated or somewhat unpredictable. Be mindful, too, that this is a painful procedure, and patients who are not sedated or given local anesthetic may move, jump, or retract from the pain, so be judicious when using needle precautions. Remember to bring ice into the room to prepare your specimen for the lab. You must assume that it could take longer than 10 minutes to get the ABG sample down to the lab and processed, so for accurate results, all ABGs must be put on ice before sending to the blood gas lab. The reason why is that oxygen continues to get consumed by the cells to maintain metabolism. If you do not get a result processed within 10 minutes, you can have an inaccurately low PaO2 resulted. When iced, this slows down the cellular metabolism and gives the sample up to 1 hour before the results are altered. I actually saw this question on a CCRN exam many years ago. And you'll want to bring a biohazard bag into the room, or use the one that comes standard in the kits to prepare your specimen to maintain the appropriate infection control standards. Okay, now that we have reviewed all the primary considerations to maintain safety and infection control, let's turn our attention to the more practical aspects of doing the procedure, beginning with just gathering up your supplies. You'll want to utilize the prepackaged ABG kits. Not only does this make your life easier, but you'll need the heparinized syringe that comes in the kit. We do have single heparinized syringes next to the prepackaged kits in the nurse server in every room, but these are intended for A-line draws. If you're going to use local anesthesia for pain control, make sure you have a 1 cc syringe and a 25 gauge needle. These are packaged together and stocked in your nurse server at the bedside. Lidocaine is stocked in Pyxis and can be pulled as an override. The ABG order per protocol includes the administration of 1% lidocaine, 0.5 mLs intradermally at the patient's request or in response to anxiety or agitation, so you don't need an additional order to cover this administration of lidocaine. Print out your lab label from CS Link and the ABG lab requisition slip before drawing your specimen. This is a strict requirement for both safety, as it allows you to do a 2-patient identifier and manages the infection control issues. Obtain your ice and biohazard bag as mentioned earlier. Find a towel roll, or my favorite, which is 2 rolled face cloths. And with these 5 items, you're pretty much ready to go. Now that you've evaluated all of your safety and infection control considerations, gathered your equipment, let's go through a final checklist to confirm a proper procedure. An MD order in CS Link. Your patient's oxygen or FiO2 is confirmed. Take a moment to make sure that you not only know that what your patient's FiO2 or liter flow is set at, but nothing has changed in the past 20 or 30 minutes to significantly affect the gas exchange prior to drawing the ABG. For example, change in FiO2 setting or suctioning, position changes, fever spikes, changes in respiratory rate or weaning parameters or vent settings. All of these things can affect the result of your ABG. So if some of those things have changed, you'll want to wait a minimum of 20 or 30 minutes before drawing the blood gas to get an accurate reflection of your patient's response. Ask yourself if the patient has any bleeding risks. If so, grab an extra 4x4 from your nurse server along with your ABG kit and allow some extra time to be certain to achieve hemostasis post-puncture. Be aware of any allergies and limit exposures. Take time to explain the procedure and answer any questions for the patient and anyone else at the bedside. This goes a long way to alleviate anxiety, promote compliance with the procedure, and also achieve success. You can begin with a simple rationale for the procedure and tie in any individualized concerns that you may have. For example, Mrs. Smith, we want to check on your blood pH and carbon dioxide level to see if you're breathing well enough now to go back on your other mask and help you get more comfortable. Remind your patient that this can be painful and allow them to reconsider lidocaine. The majority of patients who have never had an ABG or are unable to recall a previous ABG puncture may assume this experience will be the same as a venous puncture, and it's not. So use the opportunity to set their expectations in line with what they're about to experience. It's a small measure that helps demonstrate your respect and can build trust. Briefly review any side effects. The primary ones are pain, bleeding, and infection. Reassure the patient that you've taken all the actions necessary to mitigate any and all of these risks. And now you're ready to get on with the procedure. So start by washing your hands. Put on your gloves and any other protective gear that you think may be necessary. Utilize your lab requisition and perform a 2-patient ID check per policy. With your patient in a supine position, palpate the radial and ulnar pulses on the non-dominant hand. Perform a modified Allen's test. Let's take a few minutes to learn about what a modified Allen's test is and how to perform it. This is a quick clinical exam that's been recommended before any arterial punctures to assess the patency of the ulnar artery and an intact superficial palmar arch. This provides the reassurance that we need that there is adequate collateral circulation in the hand. To do this, just raise the patient's hand over their head and ask them to open and close their hand if possible. This forces blood from the hand. Use direct pressure to compress both the ulnar and the radial artery, obstructing blood flow. Now, lower the patient's arm below the level of the heart and unclench their fist and observe for pallor. Now, release the pressure from the ulnar artery only. Return of color within 7 seconds indicates patency of the ulnar artery and an intact superficial palmar arch, indicating a positive Allen's test. If color returns within 8 to 14 seconds, the test is considered equivocal. If it takes more than 15 seconds to observe perfusion, the test is considered negative, and this is a contraindication to proceed with an ABG puncture. Cedars-Sinai policy states that if flushing returns in 10 to 15 seconds, this indicates a positive finding, permitting the use of that site for an arterial puncture. So one more time, let's review the interpretation of the modified Allen test results. So return of color within 7 seconds demonstrates adequate collateral circulation and a positive Allen's test. Return of color within 8 to 14 seconds is considered equivocal or positive, permitting ABG puncture. Return of color over 15 seconds is defined as a negative Allen's test, in which case the ABG puncture should not be performed on this site. Go ahead and check out the opposite hand with a modified Allen's test. Alright, let's continue now with the rest of the steps to prepare for the arterial puncture. Now that you've confirmed collateral circulation, palpate for the radial pulse. Remember to get your patient in a comfortable supine position using a towel to hyperextend the wrist. Cleanse the site, preferably with 2% chlorhexidine-based antiseptic. If needed, administer the intradermal lidocaine through the 25-gauge needle, injecting 0.2 to 0.3 mLs until a bleb is formed. I find usually this is plenty of lidocaine. Make sure you aspirate back prior to injecting the lidocaine to be certain that you haven't inadvertently entered a vessel. Explain to the patient that they may feel a warm or burning sensation with the injection. Gently compress the injection site with an alcohol prep to diffuse the lidocaine around the puncture site. Your patient is thoroughly prepped now, so let's continue with the arterial puncture procedure. Uncap the needle now and withdraw the plunger 1 to 2 mLs. Palpate the thumb side wrist to pinpoint the exact location of the radial artery. Now palpate and stabilize the artery with your index and middle fingers of your non-dominant hand. Hold the syringe like a pencil and puncture the site slowly, bevel up. I find using a 45 to 60 degree angle works best, but you're certainly acceptable to do a 30 to 60 degree angle. Once under the skin, direct the needle slowly towards the artery until a flash of blood is noted in the hub. If no blood appears, be sure to retract the needle to the skin level before redirecting the needle towards the artery. This technique basically gives you another chance without having to perform a second puncture. But remember, excessive probing of the artery may cause injury to the vessel itself or injury to the nerve. Once a blood flash appears, pulsation of the blood into the syringe verifies that the artery has been punctured. Obtain 1 ml of blood. A sample, a sample may be accurately run on as little as 0.2 mLs of blood. But sample volumes may vary depending on the equipment used, so it's optimal to get 1 ml. You'll want to go ahead now and withdraw the needle while stabilizing the barrel of the syringe. This can prevent inadvertent aspiration of air into the syringe. Press a gauze pad firmly over the puncture site for at least 5 minutes or until hemostasis is established. Never ask the patient to assist in applying pressure. Their condition is unpredictable, and this practice may leave them vulnerable to bleeding and to hematomas. So great, now you have your specimen. Here are a few quick tips to get your specimen to the lab for processing. First, you'll want to place the blue filtered cap on top of the syringe. Check the syringe for air bubbles. Gently flick the barrel of the syringe to get any air bubbles to rise and express them through the filtered cap. Be careful to not to occlude the filter with the tip of your finger, as the air cannot be evacuated. The pressure will build up in the syringe, and as you push the plunger, you could wind up with a blood exposure. Now gently roll the syringe for 30 seconds to mix the blood and heparin to prevent any clot formation. Be sure to label the specimen and immerse the sample on ice and place in a plastic biohazard bag. Complete the documentation on the lab requisition slip and in CS Link. Be sure to discard used supplies appropriately and send to ABG Lab. Results should be posted within 10 to 15 minutes. Now let's quickly review the expected outcomes. Accurate results, of course, as you've obtained, prepared, and sent your ABG per protocol. You'll expect that your puncture site would remain free of hematoma, hemorrhage, or infection. You'd expect your patient's peripheral vasculature and neurovasculature systems remain free of complications. And of course, alterations in the ABG results would be identified and treatment options would be provided. Now let's talk in more detail about unexpected outcomes. Two types on unexpected outcomes to consider: those that occur during the procedure and those that occur post-procedure. Let's look at those occurring during the procedure first. One expected outcome here may be pain. This isn't really considered a complication per se, but should be addressed prior to the procedure to minimize your patient's discomfort and offset any complications that it could impose. But the most common complication during the procedure is vasospasm, making obtaining your sample very, very difficult. Now let's look at the post-procedure complications. These result from a compromise in blood flow leading to color, size, temperature, sensation, or pulse changes to the extremity. It also includes bleeding, hematoma, and infection at the puncture site. Providing judicious patient monitoring and care is the best way to offset unexpected outcomes. Observe the puncture site for evidence of hemostasis. Post-puncture bleeding can occur in any patient, but it's more likely in coagulopathic patients and those on anticoagulation therapy. I've gotten into the practice of holding pressure until hemostasis has been established. I then prepare my specimen in the room, and before leaving the room I go back and I take a look again at the puncture site just to make sure there's no bleeding. I go ahead and send the sample to the lab, and I try and make it a point to return to the patient's bedside just one more time to check on the puncture site. It only takes a couple of minutes, and it really helps to ensure the safety of your patient. Continue to observe the puncture site for signs of peripheral vascular and neurovascular compromise distal to the puncture site with your Q4-hour assessments. Also look for signs and symptoms of infection to determine if further treatment's needed. Monitor for pain and consider pain interventions. Now let's discuss what conditions should be reported if they persist despite some basic nursing interventions. Some reportable conditions are excessive bleeding despite the application of appropriate post-puncture pressure. Also blood loss with associated changes in vital signs, or hematomas or internal bleeding into dependent areas of the limb. Another is changes in color, size, temperature, sensation, movement, or pulse in the affected arm. You'll want to report erythema, warmth, hardness, tenderness, and pain. And finally, you'll want to report any purulent drainage at the puncture site. That would be a clear sign of infection for sure and require notification to the physician team as well. Okay, we've covered the arterial puncture protocol, specimen handling, and post-procedure care. We'll take the rest of the certification class offline with a quick quiz and a skill demonstration. Thanks so much for your attention.